Okay, so we'll talk about chapter 10, which are the drug therapy for mental health and behavioral problems. So, before we talk about the medications, so let's talk about mental health, right? And what's going on so that we can understand how these medications work. We have to understand like what's the problem, what's causing the problem, and so we can understand how the drugs help to correct the problem. Also, mental illness. Mental illness is a condition in which an individual experiences significant changes in the ability to think, as well as changes in behaviors and emotions. The person often has difficulty in coping with normal stressors, interacting with others, and otherwise functioning within his or her own cultural norms. So, when we were doing MedSearch 1, we talked about, the health and the illness continuum. So, if you recall, I mentioned it that before, long time ago, they believe that the health and the illness, they were two different entities, right? If you're healthy, then you're healthy. If you're ill, then you're ill. Those are two different things, and there's nothing in between. But because of research, so they changed it and it became a health and illness continuum. But today we're talking about mental illness, so we'll talk about the mental health and the illness continuum. If you look at your book in page 184, you're going to see in the bottom, you're going to see the mental health and the mental illness continuum. It means that, if you're having occasional stress to mild stress, then you're healthy, your mental health is healthy, there's no impairment. Or you can be in between, right, in the middle. But if you go to the other side of the continuum, where you can have your emotional problems or concerns, you have mild to moderate distress, mild or temporary impairment, and then you can also go all the way to the other side of the continuum, which is the mental illness. This is where you're going to have your marked distress, your moderate to disabling or chronic impairment, right? And then we'll also talk about neurotransmitters. So in chapter 9, we're talking about this chemical neurotransmitters, where how the neurons talk to each other or communicate to each other. And in chapter 9, we talk about the neurotransmitters and how they work, how they transmit messages between the brain and other areas of the body with the movement. For this chapter, we'll talk about how these neurotransmitters affect our memory, our mood, and our affect. Because it's important. It's important for us to understand how these neurotransmitters affect us when it comes to our mental health. So there's neurotransmitters, serotonin, dopamine, norepinephrine, and your GABA, your gamma aminobutyric acid, acetylcholine, and histamine. For if you look at page 185 in your book, let's look at it. So you can see the neurotransmitter norepinephrine. It affects our sympathetic nervous system, your fight or flight response, your alertness, and your arousal. Possible changes in mental health and illness, this is decreased for depressed people, decrease in depression. Let's talk about your serotonin. Serotonin affects our sleep, appetite, pain, and mood, also decreased in depression. For your dopamine, this is affecting our learning, movement, motivation and drive, attention, pleasure, and reward. and this is increase in schizophrenia. For your GABA, this is an inhibitory neurotransmitter, if you recall, and this affects our sleep, our muscle tension, and sedation, and this is decrease in anxiety. Your acetylcholine, which affects the parasympathetic nervous system, and this is decrease in Alzheimer's disease. Okay, now we'll talk about the medications that we use for the mental health problems. You have your psychotherapeutic agents. We have our anti-anxiety for anxiety, your antidepressants for depression, antipsychotic drugs, your anti-manic drugs, your sedative hypnotic medications. Okay, so sedative hypnotic medications, we use these medications for sedation. Sedative agent, it relaxes the patient and it allows them to go to sleep. We also have some hypnotic agents that helps produce sleep for those who are having trouble sleeping, for your insomnia patients, right? And then we also use it to relax patients and induce sleep before medical testing to kind of like calm them down, and surgical procedures. We can use them to treat insomnia caused by mental and physical stress. Sedative hypnotic medications, if you recall your benzodiazepines and benzodiazepines agonists, they enhances the effects of inhibitory neurotransmitter GABA, resulting in sleep and muscle relaxation. Remember GABA, the neurotransmitter that is responsible for sleep, muscle tension, and sedation. So when you have a patient that is anxious, that has anxiety, this GABA is decreased. So that's why you're gonna give your medication that enhances the effects of the GABA, or benzodiazepine agonist that has the same effect as your GABA. If you look at your book, page 186, it's talking about the benzodiazepines that are approved for sleep and your benzodiazepine agonists and benzodiazepines approved for anxiety. So if you recall your benzos, these are the medications that end with AM, right? Your alprazolam, lorazepam, temazepam. That's how you will recall your benzodiazepines. So let's go over the benzodiazepines that are approved for sleep. These are your estazolam, flurazepam, and your temazepam, or your Restoril. Nursing implications, ask women if they are pregnant because these drugs have a high risk for causing birth defects, meaning your pregnant patient cannot have this. Okay, we cannot use this for pregnant women. And then, of course, you tell your patient not to drive or operate dangerous equipments because we already know benzodiazepines, the effect is sedation. The effect is that they're going to be sleepy, right? So it's very dangerous for them to drive or to operate dangerous equipment because there's a high risk for injury. And then the fourth one, tell the patients to only take the drug if they have sufficient sleep time available to prevent confusion and other effects while awake. So you're going to tell your patient if you're anticipating that you're going to get up at 3 a.m. in the morning to go to work, or something that you need to do that early, then don't take the medication because it doesn't make any sense for you to take the medicine and then you're gonna wake up very early, and then you'll be loopy and drowsy and lethargic, right? And it's also increasing the risk for injury. Now let's go over your benzodiazepine agonist. Benzodiazepine agonist, this is your lorazepam, the very common lorazepam. Ativan is the other name. Okay, don't forget that now. Very common. Lorazepam, Ativan, and then the other one that is also common is your Zolpidem or your Ambien. But then you also have your Lunesta, your Esopiclone, and your Sonata, which is your Celiplone. Nursing implications highlight the first one, suggest that patients have a family member or close friend with them when they first start taking the drug because incidences of sleepwalking, sleep eating, and sleep driving have occurred. And we already know to tell the patients not to drive, not to operate dangerous equipment. Your medication Lunesta, which is your Esopiclone, this will have a metallic taste in the mouth. So you can educate your patient that this is expected. So don't freak out. Another thing you tell the patient, you don't take the sedative with alcohol. Why? Because it increases the CNS depressant. So if you're taking the sedatives with alcohol, that it will increase the CNS depress effect, right? You can have your patient, the CNS will be really, really depressed, respiratory rate will go down, your patient might even go into coma and even death. And then highlight also to report agitation to the healthcare provider as this may be a side effect of your Esopiclone, your Lunesta. So you're gonna give a benzodiazepine agonist, and the effect that you're looking for is that it will calm the patient down, right? But then your Lunesta actually has a side effect of agitation. So watch out for agitation when you're giving your Lunesta. And then you highlight to monitor the patient's level of consciousness carefully because higher doses can lead to greater risk of daytime memory impairment and decreased alertness. All right, and then you have your benzodiazepines that are approved for anxiety. Okay, you have your alprazolam or your Xanax, your diazepam or your Valium, and your lorazepam, your Ativan. For this, highlight the second one, provide patients with the call light and remind them to ask for help if getting out of bed because these drugs can cause dizziness and drowsiness. So now you're gonna help your patient go to sleep or help sedate your patient or help them calm down for anxiety, but then you're also going to put them on fall risk protocols because they're at high risk now for falling, right? Because they're so sleepy, they're so drowsy. If they get up, then they might fall. So put them on fall risk protocols. And then highlight the fourth one where it says these drugs are intended for short-term use because they can cause physical dependence. So that's why healthcare providers they limit these drugs to um, very short-term use because there's a high risk for physical dependence because a lot of people they like the sedating effect of these medications so they become very dependent to it. And then highlight the six nursing implications. It says benzodiazepines should not be used in older adults because they are known to increase the risk for falls and mortality. Yes, this is true. For your older population, we try to limit this. We try to limit giving the benzodiazepines to this population because of the increased risk for falls, which we already mentioned, and mortality. And then you can highlight the last one. Teach the patient to avoid using nicotine products, such as your cigarettes and chewing tobacco, or drinking caffeinated beverages, coffee, tea, and cola, because they can decrease the effect of your anxiolytic drugs. makes sense, right? Um, Caffeinated drinks, they keep you awake, right? They keep you alert. So it actually contradicts the effect of your benzodiazepine. So if you're gonna give benzodiazepine to your patient, your goal is to calm them down. So that's why you tell them to avoid nicotine products, and then drinking caffeinated beverages. Okay. Okay, let's talk about anxiety. So anxiety, it's very normal, right? Everybody experiences anxiety. Sometimes we feel that. We feel like our heart rate rises, we're breathing a little faster, we're irritable, we feel tense, and there's like situations, but it really depends on the situations, on why you're feeling anxious. So it's normal. It's normal in our everyday lives. Anxiety, we talk about anxiety because it can be mild, moderate, or even severe. We call the anxiety disorder if a person is having this anxiety chronically. It's chronic and it's disabling. Okay, so that's what we call anxiety. So in in a regular person, or a person without the anxiety disorder, we can do breathing exercise, we can do distraction, or you will feel sad for a little bit and then you'll move on, right? For people with anxiety disorder, these things that you can use for your everyday life, it's not gonna work for them. Okay, you cannot use distractions or your breathing relaxing breathing techniques, right? It's not gonna work for them. So that's why they require for us to give medications to treat the anxiety. Now, your benzodiazepines that we talked about earlier, your alprazolam, your Xanax, your diazepam or Valium, and your lorazepam or Ativan, they are also what we call anxiolytics. We use them also for anxiety. They're benzodiazepines, but we can also use them for anxiety. But there's also some drugs that we use for anxiety. We have your selective serotonin reuptake inhibitors, which are your SSRIs, and they are antidepressant, and also serotonin norepinephrine reuptake inhibitors, which are your SNRI, which again is an antidepressant, but we can also use them for anxiety. So the choice of drug that we give for the those patients that have anxiety disorder, it really varies according to the need of the patient, including whether the anxiety is an acute or a chronic condition. So it really depends on that. So if you look at your book, page 187, the drug that is used for anxiety, miscellaneous, your Buspar, your Buspirone or Buspar. We already know to teach nursing application, we already know to teach the patient to avoid driving, operating machinery, and then you tell the patients that the drug may be taken with or without food, but should be taken the same way each time to avoid inconsistency in the dosage. And then the last one, this is very, very important, okay? You remind your patients to avoid eating grapefruit or drinking grapefruit juice while taking buspirone because it can increase the effect of the drug. Okay, so again, anxiety is common, but it's problematic when it interferes with a person's ability to perform activities of daily living. Anti-anxiety agents, Like I said, we call them anxiolytics. We talked about your benzodiazepines, your benzodiazepine agonists, certain antidepressants, which are your SSRIs, your SNRIs, which we'll talk about later on when we talk about depression. And again, the action is producing a calming effect. And we use it to relieve anxiety, tension, and fear. And sometimes we even use it to manage those withdrawal symptoms, or we use it before operation for surgeries. And sometimes we can even use this to relieve muscle spasm. Your diazepam, your Valium, we use this for this muscle spasm. So drug interactions, there will be drugs that will increase the effects. If you give your benzodiazepine with any other drug that causes the depression of CNS, making the depression deeper, remember what I said, it can even lead to coma and death. So you don't combine them with those drugs that cause CNS depression. And then I also mentioned the antagonized effects of your caffeine and your nicotine products. It reduces the effectiveness of your sedative drugs. Okay, now I need everyone to remember this medication, flumazenil or your romazicone. This is what we call the antidote. Okay, this is a benzodiazepine receptor antagonist, and we use this medication as an antidote to reverse an overdose of benzodiazepine. Again, I will repeat it. Remember this medication, flumazenil or your romazicone, because this is the antidote to reverse an overdose of your benzodiazepines. More nursing implications and patient teaching for your anti-anxiety agents. Of course, you're going to ask your patient what are the other medications that you're taking. Ask for over-the-counter drugs, because remember what I just said, that if they're taking drugs that can increase the effect of the CNS depression, it could be dangerous, right? Level of consciousness of your patient and history of falls. Again, your benzodiazepines, your anxiolytics, they will make your patient drowsy, sleepy, right? So it's increasing the risk for falls. So make sure you are assessing the level of consciousness of your patients if there's any history of falls. Your confused patients, very high risk for injury. Then also ask for alcohol use. Alcohol use, like we said, increases CNS depression. Pregnant women, you remember your benzodiazepines, your esazolam, temazepam, your flurazepam. They cannot be used with pregnant women. And then you evaluate after you give the medication. You evaluate the drug effectiveness. You go back 15 to 30 minutes and see if the patient is now calmer. Is your intervention effective? But you're also going to check for the side effects. You're going to check the respiratory rate and the respiratory depth of your patient. Continuing on the nursing implications of patient teaching, we already know dosing. You tell your patients never to double dose. If they miss a dose, you don't double dose. It's very important for them to follow up, make a follow up, and don't miss any of their appointments. Remember, these medications are being used only for short term. So the way it works is the healthcare provider will actually give them a prescription for just a certain amount of time. For example, I'm going to give you a prescription for diazepam, for example, your Valium, for only 2 weeks. So in 14 days, that patient is supposed to go back to the healthcare provider for a follow-up appointment, and then the healthcare provider is going to check if the medication or intervention is actually effective so they can continue giving the medication. Okay, We already know the adverse effects, to educate our patient, drug and alcohol interactions. And then once again, very important to remember, your benzodiazepine has a very high risk for dependence. Okay, it's habit forming. So that's why we give it for a short period of time. We do not give it no longer than 2 to 3 weeks, and only when needed. Okay. Okay, antipsychotics. So, before we talk about the medication, the antipsychotic drugs, let's talk about psychosis first. So, psychosis is defined as a loss of contact with reality. So, psychosis differs, it varies from person to person. It can develop over a few hours or days, or this is what we call the acute or your delirium, or it can develop over months or years, such as your schizophrenia or your bipolar illness. So it could be chronic, it could be acute. So delirium, your acute psychosis, this is considered acute, and then the patient experiences a sudden change in their awareness and attention that is related to problems in the brain. So these are your patients that have been alert and oriented, and then all of a sudden, right, they become confused, or they are not, there's a loss of contact with reality. They might be hallucinating, they might be delusional, and there might be causes, right? Like you have your patients, for example, that have UTI. They used to be alert oriented, and then one day, your patient will start being confused. You're gonna see that they're more confused than usual. And then you do the labs, you check the urine for UNCS, and then they will come back as positive for UTI. Just an example. That could be an example of your acute or delirium. Okay. Or you have your patients that went into surgery, and then when they come back, they're confused. That's your acute delirium. It's sudden, but then it develops over a few hours or days. Okay. And then we'll talk about the chronic one, the chronic psychosis. These are the patients with chronic mental illness, such as your schizophrenia and your bipolar illness. They have symptoms that increase over a long period. Okay? Again, your patient might be delusional or hallucinating. It could be months or even years before the patient is diagnosed. And then, the family around them, they may notice the changes in behavior, but they're like, what's going on? They're not aware of what really the problem is until it becomes, more severe and more pronounced that they're gonna ask for help. Okay, so symptoms of psychosis, you have your positive symptoms and you have your negative symptoms, which we'll talk about in a little bit, your box 10.1. But going back to your medications for psychosis, you have your typical antipsychotic drugs and you have your atypical antipsychotic drugs, and we'll go over them in a little bit. Okay. But before we go over the drugs, the antipsychotic drugs, let's look first at page 189, your box 10.1. That's the example of your positive and negative symptoms associated with schizophrenia. So you have positive symptoms. This is something that is present that is not normally present. Your hallucinations, either visual or auditory, your delusions, holds a belief without any evidence, disordered thinking, unusual ways of thinking, speaking, your agitation or other bizarre behavior. And then you have your negative symptoms. This is something that is absent that is usually present. So, lack of motivation. Your patient now is very depressed, sad, isolated. They have a flat affect. There's a decreased facial expression or tones with emotion. There's a decrease in personal hygiene. All of a sudden, your patient does not want to shower, does not want to brush their teeth, does not want to shave, change their clothes, or lack of social interest. Again, isolating themselves in the rooms, right? Okay, now let's talk about the typical antipsychotic drugs. So, typical antipsychotic drugs, these are the first generation of this drug type. They act by blocking the action of your dopamine in the brain because schizophrenia is a disease of overstimulation of dopamine receptors from presence of too much dopamine. So, going back to your Parkinson's disease, right? Your Parkinson's disease, decreased dopamine. Your schizophrenia, too much dopamine. Okay? So schizophrenia, disease of overstimulation of dopamine receptors because there's too much dopamine. So we use typical antipsychotic drugs as a treatment for severe mental illness. What are the expected side effects of or adverse effects? You have your headache, drowsiness, nausea, constipation, your dry mouth, and then we talked about EPS before in class. Your EPS, your extrapyramidal symptoms, and we'll talk more about that later on. You have your pseudo-Parkinsonism, acute dystonia, akathisia, and your tardive dyskinesia. Remember the involuntary movement in the lower part of the face. Your neuroleptic malignant syndrome. Okay, and we'll look into it later on. Your figure 10.2, which is, hold on, here in page 192. So let's look at it first before we go over the medication. These are the side effects of taking antipsychotic drugs. Okay, looking at the book, page 192, your pseudo-Parkinsonism. You look at it, they have a stoop posture, shuffling gait, rigidity, bradykinesia, tremors at rest, peel rolling motion of the hand. So you're gonna look like they have Parkinson's. They have acute dystonia. They have a facial grimacing, involuntary upward eye movement. They have muscle spasms of the tongue, face, neck, and back. And then they have the laryngeal spasms. And then your akathisia. Look at the foot, the movement of the foot. It's restless. They have trouble standing still. They're pacing back and forth. And they have a constant motion of their feet, rocking back and forth. And then your tardive dyskinesia. This is what I was talking about the other day while we were in class. They're protruding and rolling their tongue. They're sucking and smacking, your lips smacking, chewing motion. They have a facial dyskinesia and involuntary movements of the body and extremities. So these are what we call EPS, your extrapyramidal symptoms. You're gonna see this very common in antipsychotic drugs, side effects of antipsychotic drugs. Okay, then let's look at page 190. These are your typical antipsychotic, again, your first generation of this drug type. They block the D2 receptors in the brain, blocking the dopamine receptors, blocking dopamine, right? So blocking dopamine can also result in a variety of side effects. Again, we just talked about this, your EPS. You have your uh, phenothiazines and you have your non-phenothiazines, okay? So under your typical antipsychotics, you have two subtypes, which are your phenothiazines and your non-phenothiazines. Your phenothiazines, these drugs block transmission of dopamine at the dopamine receptors and other neurotransmitters at acetylcholine and alpha adrenergic receptors. So, very common on this medication is your thorazine. The first one, chlorpromazine, your thorazine. And then we can also give the fluphenazine. This is oral or also can be given IM. intramuscular. Nursing implication, we recognize the signs of EPS, we just talked about that, because many are severe and some may be irreversible. They can occur in as many as 10% of patients who take these drugs. Second one, you teach patients to avoid becoming dehydrated, participating in strenuous exercise, or extremes in temperatures because these drugs may affect the body's ability to regulate core body temperature. And then your third one, you report sudden increases in blood pressure, increase in temperature, and confusion. May indicate signs of neuroleptic malignant syndrome. So write this down. Your patient that is taking thorazine or your chlorpromazine, watch out for hypothermia, because they're gonna have problems with regulating core body temperature, or watch out for your neuroleptic malignant syndrome, and we'll talk about that later. Okay, now you have your non-phenothiazines. Non-phenothiazines, these drugs have similar actions to the phenothiazines, but they are chemically different from the phenothiazines. So it's just a chemical difference. Side effects and adverse effects are similar, and it's the very common one that we use is your haloperidol, your Haldol. Okay, Haldol, it can be given either orally or intramuscularly. Side effects and nursing implication is the same. I don't have to repeat them. But again, don't forget about monitoring them for hypothermia and monitoring them for neuroleptic malignant syndrome. Okay, let's talk about neuroleptic malignant syndrome because we just mentioned it. If you look at page 192, your box 10.2, these are the signs and symptoms of neuroleptic malignant syndrome. So this is what you're going to watch out for when you're giving your typical antipsychotic, okay? You're going to watch out for sudden elevated temperature, increased white blood cell count, muscle rigidity, unstable blood pressure, elevated serum creatinine kinase, and your hyperkalemia. We talked about the typical antipsychotic. Now we'll talk about the atypical antipsychotic. So atypical antipsychotic, this is the second generations of this drug type. The actions, it blocks the dopamine 2 and other subtypes of dopamine receptor, as well as certain subtypes of serotonin. It is used primarily for schizophrenia, but also can be used for bipolar illness and schizoaffective disorders. And then we're gonna watch out for their side effects: your insomnia, your drowsiness, sexual side effects, decreased libido, dizziness, orthostatic hypotension, constipation, and dry mouth. And then your atypical antipsychotics, they have lower rates of your EPS. The nursing implications and patient teaching. Let's look at page 191, table 10.3. So again, atypical antipsychotics, the majority of these drugs are a combination of dopamine and serotonin blockers. These drugs can reduce positive symptoms and improve negative symptoms without the severity of your EPS that you can get from the typical antipsychotics. So what are the common antipsychotics? You have your risperidone or your Risperdal. Again, can be given orally or IM intramuscularly as a depot drug. Depot drug, so we give this IM intramuscular depot shot. This works just like your birth control ones. So you're gonna give the IM and it's gonna be, the effect is gonna be slow, but it's gonna stay in the system longer, right? You can give this every 2 weeks, or we even have if you go back to your Haldol, your haloperidol, we have IM depot injection for that medication that we can give the patient at least once a month. Okay, and going back to the book, you have your ziprasidone or your geodone, and then the common one, which is your Seroquel or your quetiapine in the bottom. Nursing implications for this type of medications. The second one, please highlight it, put a star, remember it. You teach the patient about good nutrition and physical activity because these drugs can cause weight gain. The third one, you monitor blood sugars for patients with diabetes or those at risk for diabetes because these drugs can increase your blood sugar. Highlight also the number 6, encourage patients to keep a diet high in fiber to avoid constipation, which is common with atypical antipsychotics. And your next one, for patients who have difficulty adhering to oral drug schedules, again, your IM depot shot, they are available. This allow less frequent dosing up to 2 weeks or even longer. And then you have your dopamine system stabilizers, your Abilify, your aripiprazole. It can be given orally, daily, or it can be given also as IM, your intramuscular. What do we need to remember for your aripiprazole? Your second one, please highlight it. You read drug information carefully when giving aripiprazole. In general, the deltoid muscle can be used for IM dose less than or equal than 400 milligrams. Doses greater than 600 milligrams must be given in your gluteal muscles. Depending on the patient and dose, these drugs can be given every 6 weeks to 2 months. Antidepressants and mood stabilizers. So before we go further, let's talk about depression. We mentioned earlier that the norepinephrine, this is decrease in depression, and your serotonin is also decrease in depression. So these are the two neurotransmitters that we're focusing on when we're talking about depression. Okay? Depression, whether mild or so severe that it interferes with activities of daily livings. Okay, so it's either mild and it's not abrupting or it's not affecting the activities of daily living, or it could be very severe that it interferes with activities of daily living. So what are the symptoms of your depression? If you look at page 195, box 10.4, your symptoms of depression, you have your abrupt changes in eating habits, chronic fatigue, being slowed down, decreased ability to perform normal daily tasks, decreased appetite or weight loss, or overeating and weight gain, difficulty concentrating, remembering, and making decisions, feelings of hopelessness and negative thinking, your pessimism, inability to experience pleasure in hobbies and experience and activities that were once enjoyed. So these are the patients that, for example, used to love listening to music. All of a sudden, you know, it's not giving them pleasure anymore. They're not enjoying it anymore. Insomnia or early morning awakening or oversleeping, irritability, numb or empty feeling or absence of any feelings at all, persistent feelings of worthlessness, guilt, helplessness, or sadness, persistent physical symptoms that do not respond to treatment. You have your headache. They might have digestive disorders, maybe nausea and vomiting, right? Or even diarrhea, constipation, chronic pain, recurrent thoughts of death or suicide, and then restlessness. So, medications that we give, what do we give for antidepressants and mood stabilizers? We have what we call tricyclic antidepressant, your TCAs. your MAOIs, your MAOIs, your SSRIs, and SNRIs, serotonin selective reuptake inhibitors, right? And then your norepinephrine, selective norepinephrine reuptake inhibitors, and then your atypical antidepressant. So before we continue with selective serotonin reuptake inhibitors, your SSRI, I need you guys to look at page 198, your table 10.4, your atypical antidepressant, the first one. These drugs work slightly differently than the other antidepressants, but do affect the neurotransmitters dopamine, norepinephrine, or serotonin. Your bupropion, your Wellbutrin. Okay, nursing implications. Please highlight the third one. Do not discontinue these drugs suddenly because the patient may experience withdrawal symptoms. And then highlight the next one, which says report any signs of agitation, irritability, or unusual behaviors to the healthcare provider because these drugs can trigger mania in some patients. Okay, that's your atypical antidepressant. Okay, your bupropion or Wellbutrin is what we call it. Okay, let's go to selective serotonin reuptake inhibitors. Before we look at that table, so SSRIs, the main goal of this drug is to increase the amount of serotonin in the brain. Remember your depression, decrease serotonin, right? So you correct it by increasing the serotonin. And this is the goal of these drugs, to increase the amount of serotonin in the brain by blocking the reuptake of neurotransmitters by the neurons, okay? So this is used for short term for treatment of outpatients with diagnosis such as your major depressive disorders, your MDD, okay? And then we can also use this long term for dysthymic and minor depressive disorders. So table 10.4. SSRIs. You have your escitalopram or your Celexa, your fluoxetine, your Prozac, paroxetine, Paxil, sertraline, Zoloft. All of them actually very common. You will see them all the time. Nursing implications. Again, please highlight the second one that says do not discontinue the drug suddenly. Oh, I'm sorry. Highlight the first one as well. Work with RN or other healthcare provider to screen all patients who are taking antidepressant for thoughts of suicide because they are at increased risk, particularly when starting to take antidepressant. Okay, let's pause here and let's talk about this. So, you have a patient that is depressed. There's a diagnosis of depression. And then you're going to start them with medication that supposedly will correct the depression, such as your SSRIs, your selective serotonin reuptake inhibitors. However, it's very important that when you start them on antidepressant, you will also monitor them for increased thoughts of suicide, increased depression. So you're giving medication to correct it, but then there's a side effect also that it may make it worse. Okay, so you monitor them for increasing depression, even thoughts of suicide. So if you're seeing any signs and symptoms of suicide or increased depression, then you talk to the healthcare provider. Um, Report it right away. Okay. All right, let's continue in the book. What else do you need to know here? All right. I think that's it. Serotonin norepinephrine reuptake inhibitors, your SNRIs. The action of this drug inhibits the reuptake of both your serotonin and norepinephrine. increasing the concentration of both neurotransmitters available to postsynaptic receptors. Again, the goal of this drug is to increase the serotonin and to increase the norepinephrine. Okay, so page 198, your venlafaxine or your Effexor, and your duloxetine or your Cymbalta. So expected side effects are the side effects that we need to look out for. You have your nausea, your dry mouth, loss of appetite, fatigue, drowsiness, sexual side effects, your epistaxis, your GI bleeding, and even liver damage. So nursing implications, again, the very first one you highlight, you monitor for increased depression and you monitor for thoughts of suicide and you report it right away. Do not discontinue these drugs suddenly because the patient may experience withdrawal symptoms. And then the one, two, three, four. The fifth one, I need you guys to highlight that and I need you guys to remember it. Remind patients that it may take several weeks for the drug to take effect, and they may not experience full benefit for 4 to 8 weeks after starting therapy. So remember that if you have a patient that is going to take or start taking your SNRIs or your antidepressant, it does not work right away. Okay, you are going to educate your patient that it's going to take weeks before this will take effect. It can even take up to 4 to 8 weeks after they start their medication. That's like a month or a month and a half, right, of taking the medication before it will even take effect. So if you have a patient that is taking an antidepressant or started an antidepressant and then came to you and said, the medication that I'm taking for depression is not working. Well, you educate that patient and say it takes some time before it will take effect. Okay, it can even take 4 to 8 weeks after starting that therapy, that medication before it will even take effect. Okay, and then the last one, the last nursing implication. You teach the patients that they may experience sexual side effects while taking these drugs and to contact their healthcare provider to discuss any alternative drugs that may be helpful. Drug interactions for both your SSRIs and your SNRIs. You're gonna watch out for any drugs, even those herbal ones that affects serotonin or norepinephrine, like your St. John's wort, okay? Because it can cause what we call serotonin syndrome. Serotonin syndrome. Okay, what is serotonin syndrome? If you look at page 194, box 10.3, these are the signs and symptoms of serotonin syndrome: confusion, agitation, restlessness, stomach disturbances or diarrhea, sweating, extremely high blood pressure, even seizures, dilated pupils, and then tremors. So when you have a patient that's taking the SSRIs and SNRIs, make sure you're screening for whatever other medications they're taking, including the herbal ones, your St. John's wort, because they can cause serotonin syndrome. Okay, TCAs or your tricyclic antidepressants. These drugs, they believed or they are thought to inhibit the reuptake of norepinephrine and or your serotonin. It increases the availability for these neurotransmitters for activation of the postsynaptic receptors. We use this to treat endogenous depression, mild depression due to exogenous causes. So, what are the expected side effects? Dry mouth, drowsiness, constipation, nausea, and orthostatic hypotension, cardiac dysrhythmias, heart failure, and then seizure. So look at your book, table 10.4, page 199. TCAs, sample of your TCAs. You have your amitriptyline or your Elavil, and you have your imipramine, your tofranil. Nursing implications. First one, you watch for side and adverse effects, especially as the dosage is being increased. And then you remind patients that current use of marijuana can cause serious cardiac problems if given with TCAs. So again, your expected side effects is your cardiac dysrhythmias. So those patients that are using marijuana, you educate them and remind them that it cannot be given, or it cannot be the current use of marijuana, it cannot be combined with TCAs because it can cause serious cardiac problems. Third one, you teach your patients that using tobacco products can decrease the effectiveness of your TCAs. And then the fourth one, TCAs should be avoided combining with your MAOIs, your MAOIs, your SSRIs, your SNRIs, because they can cause an increased risk for serotonin syndrome, which we just talked about. And then the last one, highlight it. Teach patients to contact their healthcare provider if they have any new or troublesome symptoms, such as difficulty urinating, blurred vision, or shortness of breath, because this can indicate adverse effects. Okay, MAOI inhibitors, your MAOIs. So before we talk about MAOI inhibitors, let's talk about the monoamine oxidase. So this monoamine oxidase, these are enzymes, naturally occurring enzymes. This is found in the body. This is found in the mitochondria of the cells. It's located in the nerve endings, kidneys, liver, and intestines. And what it does is it normally acts as catalyst. Catalyst meaning it's breaking down, it's destroying to inactivate dopamine, norepinephrine, epinephrine, and serotonin. So this monoamine oxidase, this is the one that's responsible for breaking down or inactivating the dopamine, norepinephrine, epinephrine, and serotonin, which means this is what's responsible for decreasing those neurotransmitters, right? So if you're blocking the effect of this enzyme, if you're blocking the effects of monoamine oxidase, that's why we call it MAO inhibitors. It inhibits that enzyme from breaking down those neurotransmitters. It's blocking the inactivation of these neurotransmitters that results in increased concentration at neuronal synapses and the antidepressant effects. Okay, look at your book in page 199, your MAOIs, your phenolzine or your Nardil, your isocarboxacid or your Marplan, and your siligaline, which is your aldapril. These are the three MAOIs, MAO inhibitors, and nursing implications. I need you to highlight all 5 of them. The first one, this drug is usually reserved for patients who have had multiple attempts at antidepressant agents without relief. So we usually try the other antidepressants first before we go and select a MAOI inhibitors. You provide the patient with information regarding foods and beverages that are high in tyramine. Remember your tyramine, your beer, your wine, your mature cheese, your smoked meats, your bologna, dried fish, sausage, salami, your caffeinated drinks, right? If you want to look at the high tyramine foods that you have to avoid when you're taking MAOI inhibitors, they are in page 203, box 10.5. And then of course, um, so you're telling the patient to avoid taking foods and beverages that are high in thiamine because it can result in hypertensive crisis, even death. Okay, so it's very, very important for you to educate the patient that's taking MAOI inhibitors to avoid foods that are high in thiamine because it can cause hypertensive crisis. Okay, and then highlight the third one. Remind patient that it can take up to 4 weeks for the patient to feel the effect. Again, your antidepressant, it takes weeks before it take effect. And then you monitor vital signs carefully. Again, remember your hypertensive crisis, right? If you take the MAOI inhibitors with food high in thiamine, so that's why you monitor the vital signs carefully. And then you highlight the last one. To avoid serotonin syndrome, you teach the patients to wait at least 2 weeks after discontinuing the MAOI before taking any drugs with serotonin. So this last one, highlight this, is very commonly asked in NCLEX and ATIs when you're taking a MAOI inhibitors, or if your patient is taking a MAOI inhibitors, you tell them, teach the patient to wait at least 2 weeks after we discontinue the MAOI inhibitor before taking any other drugs with serotonin. Expected side effects or adverse reactions for your MAOI inhibitors. You have constipation, headache, dizziness, drowsiness, dry mouth, liver damage, a variety of blood disorders, or again, the thoughts of suicide, which I have explained earlier. And drug interactions, like we said, you do not combine your MAO inhibitors with your SSRIs, SNRIs, and your St. John's wort because it can cause the neuroleptic malignant syndrome or your serotonin syndrome. Okay, mood stabilizers. Mood stabilizers, these drugs are used primarily to treat patients with bipolar illness, but it can also help to reduce the symptoms of um, depression. Okay, some of them we're gonna talk about them, but some of them we talked about when we talk about the epilepsy. They are anti-seizure drugs, but they can also be used as a mood stabilizers. So lithium is the first one. The exact mechanism of lithium's action is unknown, but it is believed that it alters the sodium transport at nerve endings and enhances uptake of serotonin and norepinephrine by the cells. So we use it as a mood stabilizers. Expected side effects or adverse reaction for your mood stabilizers, you're going to have your mild weight gain, increased thirst, increased urine output, and your dry skin, hypothyroidism, renal failure, and your diabetes insipidus. So looking at your book in page 199, in the bottom, your mood stabilizers, you're going to have your lithium, your valproic acid, which is your Depakote, and your carbamazepine, which is your Tegretol. If you recall, there's last two medications, your valproic acid, your Depakote, and your carbamazepine, your Tegretol. We mentioned them when we were talking about epilepsy because they are actually anti-seizure medication, but we can also use them as a mood stabilizer. Okay, nursing implications for your lithium and your carbamazepine. You monitor the serum blood level because they have a narrow therapeutic range. Narrow therapeutic range meaning the therapeutic dose is very close to the toxic dose. So you monitor carefully for side effects and adverse effects because of this reason. And then the second one, you teach the patient to avoid conditions that result in severe sweating or potential for dehydration because this can result in low sodium and increased risk of lithium toxicity. Next one, you teach the patient to avoid reducing salt intake. Sodium is needed in the diet to prevent lithium toxicity. So remember this, when you're giving your patient lithium, it's very important that they have good control of their sodium level, because um, low sodium or your hyponatremia, it can cause lithium toxicity. Patient will need to have regular serum lithium levels drawn to help prevent lithium toxicity. We just talked about that. Narrow therapeutic range. And then risk factors for lithium toxicity include older age, your kidney disease, your low sodium levels, dehydration, heart disease, debilitated state, and taking certain drugs such as your ACE inhibitors, your diuretics, and your NSAIDs. And then it's okay to mix lithium oral solutions with fruit juice or flavored drinks, but do not mix them with other drugs because they can form an insoluble soluble salt. And then we talk about the carbamazepine serum blood level that we have to monitor. Normal serum carbamazepine level is 8 to 12 mcg per ml. And that wraps up chapter 10, your drug therapy for